Evening, everyone. So, my next topic of the video, which I'm going to discuss with you, is on the drug interactions. Certain drug interactions I will discuss with you, and I will discuss the drug interactions in 3 videos. And now I'm starting my first video, in which I will discuss with you 4 drug interactions. And I hope you like this video. And if you like this video, kindly subscribe to my YouTube channel. This is Dr. Nitika Pharmacology Discussion. Now I'm going to discuss with you some drug interactions. So first is the rifampicin and oral contraceptives. A 30-year-old married female presented in OPD with chief complaints of cough with expectoration since 1 month, fever and shortness of breath since 1 week. Based on chest X-ray findings and sputum smear for acid fast bacilli, she was diagnosed to be suffering from pulmonary tuberculosis and was prescribed isoniazid, rifampicin, and pyrazinamide and ethambutol for 2 months, after which she was called for follow-up. On follow-up visit, she informed that she had got pregnant despite of taking combined oral contraceptives regularly for the past 1 year. What do you interpret of this clinical scenario? Which preventive steps could have been taken to avoid this scenario? So the patient was on anti-tubercular therapy. She was having symptoms of expectoration with cough with expectoration, fever, and shortness of breath. She was found positive for acid fast bacilli, and she was prescribed isoniazid, rifampicin, pyrazinamide, and ethambutol. And now she was on oral contraceptives also, but she was for the past 1 year, but she became pregnant. So what was the reason? In the above case, there occurred pharmacokinetic interaction at the level of drug metabolism. Rifampicin, who is a potent microsomal enzyme inducer, induces the metabolism of oral contraceptive pills and reduce their plasma concentration. They will induce the metabolism of the oral contraceptive pills, and the plasma concentration of oral contraceptive pills will be reduced by the rifampicin, which is the potent microsomal enzyme inducer. There occurred failure of contraception because of decreased plasma concentration of the oral contraceptive pills. Proper history should have been taken regarding OCPs. Means proper history should have been taken before prescribing regarding the OCPs. Management adopt another type of contraceptive method while the patient is on anti-tubercular therapy. We can adopt any other contraceptive device. And oral contraceptive pills with higher estrogen levels can be used. The dose of OCPs can be increased, but warned for risk of contraceptive failure in areas because of the high dose. Means dose of the oral contraceptive pills can be increased, but we should warn that there can be high dose toxicity can occur because of higher dose. And we have to use rifabutin in place of the rifampicin. We can use rifabutin, which is the safer drug, which doesn't cause the microsomal enzyme induction. So instead of rifampicin, we can use rifabutin. So next is probenecid and cephalexin. A 23-year-old male came to OPD with a urinary tract infection. He was prescribed cephalexin along with probenecid twice a day. What is the rationale of giving probenecid along with cephalexin? So a 23-year-old male, he came to the OPD with a urinary tract infection, and he was prescribed cephalexin, which is cephalosporin, and probenecid. So what was the rationale? The rationale is the probein is that it competes with or it inhibits the tubular secretion of the beta lactams. So the beta lactams will not be secreted to the tubules. So the concentration of beta lactams will increase in the blood, and it will also increase the duration of action. So once daily dose can be sufficient. And so we can give the cephalexin in lesser dose, and frequency of administration should also be less, and cost of the drug will also be less, because the levels of the drug levels of cephalexin in the body will increase because it inhibits the proteinases, inhibits the tubular secretion. So less frequency of administration also increases the compliance of treatment. So when the frequency is reduced, the compliance can also be better. because a bit of dose, when we give a slow dose, it will have a prolonged effect, higher effect, because tubular secretion is inhibited by the rubin acid. NSAIDs and fluoroquinolones. A 54-year-old female patient of osteoarthritis on tablet diclofenac 100 milligram twice a day since 1 year presented with in OPD with foul-smelling loose stools 3 to 4 episodes from last 2 days. She was presented with tablet ciprofloxacin 500 milligram twice a day. The patient reported with seizures after 3 days of starting the medication. So what could be the possible cause of seizures and how will you manage the patient? So now the fluoroquinolones are given, when the fluoroquinolones are given with the non-steroidal fluoroquinolone, ciprofloxacin was given for the loose stools, and the patient was a known case of the osteoarthritis, so he was prescribed as I NSAID also. So NSAID, what do they do is they augment the displacement of GABA from its receptor by the quinolones. Because they will augment the displacement of GABA. GABA is the inhibitory type of the receptor and it will be displaced from its receptors. And the quinolone, thus the quinolones will result in dizziness, headache, hallucinations, delirium, and seizures. Therefore, the concomitant use of fluoroquinolones and NSAIDs should be avoided. Because we should not use the fluoroquinolones and NSAIDs together because that can lead to seizures because of the displacement of GABA from the receptors. ACE inhibitors and NSAIDs, a 45-year hypertensive male was on tablet enalapril 10 milligram BD presented to medicine OPD with complaints of fever, myalgia, and joint pains for the last 5 to 6 days. Now he was suffering from hypertension and he was given enalapril 10 milligram BD and and he complained of the fever, myalgia, and joint pains for the last 5 to 6 days. So on examination, BP was found to be 130 by 80 millimeter of mercury, and he was then prescribed tablet ibuprofen, which is 400 milligram BD. So he was then prescribed tablet ibuprofen, 400 milligram BD, and on follow-up after 15 days, the patient came to the OPD with complaints of headache, body fatigue, and BP, which was found to be 150 by 100. Means BP was raised, and the patient was complaining of headache and body ache, and despite taking enalapril. So what could be the possible reason for this? So ACE inhibitors act by partly preventing the breakdown of kinins that stimulate prostaglandin production. Because they will inhibit the breakdown of kinins, these ACE inhibitors, and that will stimulate the prostaglandin production. And prostaglandins, they lead to vasodilatation, they decrease the peripheral vascular resistance, which in turn leads to decrease in blood pressure. Thus, it is logical that NSAIDs might attenuate the effectiveness of ACE inhibitor. Now, they will decrease the effectiveness of ACE inhibitors because they block the production of prostaglandins. Prostaglandin production will be decreased. So, they have a vasodilator and natriuretic effects. So, NSAIDs attenuate the effectiveness of these ACE inhibitors. So, so that's why the patient suffered from hypertension because the effectiveness of ACE inhibitor was decreased. And also NSAIDs and ACE inhibitors, they precipitate hyperkalemia, which can cause arrhythmias leading to syncope, especially in the elderly and in the patients with diabetes mellitus, hypertension, and ischemic heart disease. So it can lead to arrhythmias, hyperkalemia, which can produce arrhythmias, leading to syncope, especially in the elderly and in the patients with diabetes mellitus, hypertension, and ischemic heart disease. That's all with the 4 drug interactions which I discussed with you. I hope you understood this video. And if you understood this video and if it is helpful to you and it is useful to you, kindly subscribe to my YouTube channel. That is Dr. Nitika Pharmacology Discussion. Thank you. Be happy, be healthy, stay safe, happy learning. All the very best. Thank you.